Hello, everyone. Good evening. I hope everyone is doing well, and I welcome you to this webinar on a very interesting, a very contemporary topic. I'm Dr. Arjun Khanna, and I practice in Delhi NCR. I'm a pulmonologist, and today's topic is it's a very interesting topic that has been picked up by Team ICS, which is targeting the unknown enemy. And I think pulmonary infections is something that we as pulmonologists, physicians, as intensivists, something that, we deal with day in and day out. And today, the way to take it forward would be, we'll be having two talks. One would be on the role of newer antibiotics in various respiratory infections. And then we have a very interesting talk on multiplex PCR, which is the new kid on the block. The talks would be followed by a panel discussion with all our experts today, and we'll be discussing various contemporary issues on respiratory infections. I would request all the participants to please keep sending your questions. Before the webinar, actually, we've got a number of questions which people have sent in, so we've already got a lot of questions, and I'm sure after the talks, we would have even more questions. So very briefly, I would introduce the fantastic panel that we have with us today. The first two talks, the first talk would be by Dr. Sachin Dodamani. Dr. Sachin is a trained super specialist pulmonologist from AIIMS New Delhi. He now works at Fortis Bangalore, and his areas of interest are interventional pulmonology, but Sachin also deals with pulmonary infections. And Sachin would be talking about the role of newer antibiotics in respiratory infections. This would be followed by the role of multiplex PCR, how to interpret a multiplex PCR report, how to go about, interpreting the resistance patterns, how to go about taking these, reports in the clinical scenario by Dr. Saurabh Mittal. Saurabh has been trained as a pulmonologist at AIIMS New Delhi. He's an alumnus of the prestigious King George Medical College, Lucknow, and now works as an assistant professor at AIIMS New Delhi. It's a pleasure having you here today, Saurabh. Followed by these two talks, we'll have a panel discussion. Of course, Sachin and Saurabh are going to join us, but then we'll have three stalwarts with us. The first, of course, Dr. Professor Pervez Kaul. He needs no introduction everywhere. The pulmonary circles, we all know him as the vaccination man of India. Someone who's the most quoted author from India, one of the highly cited, the most cited scientists from the country. Sir's work spans all across pulmonary medicine. His areas of interest are, of course, pulmonary infections, influenza, respiratory vaccinations, and always a pleasure listening to Sir and always something to learn from him. Fantastic having you here, Sir, today, and looking forward to learning from you. Then we have Dr. Nitin Abhyankar, who of course needs no introduction. Sir is an interventional pulmonologist, a pulmonologist based at Pune. And whenever you talk about thoracoscopy, the word, Dr. Nitin Abhyankar's picture comes into my mind. And always someone who comes up with fantastic points and always something to learn from him. Thank you so much, sir, for being here with us today. And then, of course, we have the young gun, Dr. Atri Gangopadhyay. Atri, of course, needs no introduction. Atri is a famous upcoming pulmonologist, does fantastic work with iOS. That is something that he's known for. And of course, as a general pulmonologist, his area of interest also include respiratory infections. So with this stellar panel that we have today, we'll be taking forward this topic. And I'm sure at the end of it, we are going to go home more intelligent and we'll be more knowledgeable about how to tackle respiratory infections. So with this, I would not take much of your time. I would request Sachin to go ahead with his talk, which is on the role of newer antibiotics in respiratory infections. Sachin, over to you. Thank you so much.
Thank you, Dr. Arjun, for that warm introduction. And let me share my screen. So I hope my screen is visible. So thank you, everyone. Thank you, ICS, Dr. Amita, for giving me this opportunity to speak on a very exciting topic, that is newer antibiotics in respiratory medicine. So myself, Dr. Sachin, I work at Fortis Hospital, Bangalore. I'm both an interventional pulmonologist and I also deal with the critical ICU in our center. So newer antibiotics is something which we all are, interested in. We all want to understand there are a lot of intricacies involved, whether which antibiotic to use, when, and why we are using these antibiotics, what is the rationale behind it. So I'll not be discussing in this talk regarding the commonly used antibiotics, the basic antibiotics, which we are all using since. What I'll be dealing mainly is the newer antibiotics, which are already available with us, which we have been using for the last couple of years, and how they have changed the role in management of the HAP and VAP in India. So my outline of my talk will be, I'll be speaking basics of the antibiotic pharmacology, what antibiotics do we already have in our hand, and why there is a need for newer antibiotics. And I'll be touching upon the newer antibiotics in respiratory medicine, which we are all using at present, and how they have a role in the management of community-acquired pneumonia, could be oral newer antibiotics, how they are useful in the management of HAP and VAP, that is the newer IV antibiotics, with relevant clinical trials of them, and I'll be summarizing the details. So going back to the pharmacology, the basics of the mechanism of action of any antibiotics, when we look into it, we see that antibiotics work either by acting on the cell wall synthesis like the penicillins and the cephalosporins, including monobactams and carbapenems, or they may act on the cytoplasmic membrane structures like the polymyxins and daptomycin. They may act on the DNA gyrase and in the form of quinolones, fluoroquinolones. We have different generations of fluoroquinolones. They may act by inhibiting the protein synthesis, either 30S or 50S ribosomal unit in the form of macrolides, lincomycin, clindamycin, tetracyclines, and aminoglycosides. And we have several other array of antibiotics. So this is the classical teaching we already know, that is the various category of antibiotics, the armamentarium of antibiotics we already have, in which we have penicillins, cephalosporins, we have carbapenems like imipenem, meropenem, ertapenem, and doripenem, monobactams like aztreonam, tetracyclines, glycocyclines like tigecycline, aminoglycosides, macrolides. We have the drugs to inhibit the folate synthesis, different generation of fluoroquinolones, drugs, antibiotics for leprosy and tuberculosis. Now, what antibiotics we already have in our hand, let us understand a bit of this. So when we look into the various infections in the ICU setting in Indian scenario, we see that the most commonly seen infections in our ICU is the respiratory tract infections, followed by abdominal, bloodstream, and urinary tract infections. So that's where the respiratory infections play an important role. And when we look into a tertiary care center, most of our prescriptions, around 90 to 95% of our prescriptions include these coamoxiclav, macrolides like azithromycin, piperacillin tazobactam, cefoperazone sulbactam, levomoxy or ciprofloxacin, teicoplanin, vancomycin or linezolid, doxy, imipenem, meropenem, colistin, polymyxin B, aztreonam, and ceftriaxone with EDTA combination. So why do we need newer antibiotics when already so many antibiotics are there in our hand? Why do we need or require these newer antibiotics? The reason we all know is the antibiotic resistance. So antibiotics targets are being attacked by the bacteria to cause antibiotic resistance, either by efflux mechanism, by immunity bypass mechanism, target modification, or by production of various inactivating enzymes in the form of beta-lactamases, for a good example. So classical bad bugs in pneumonia in the respiratory medicine, we call them as escape bugs. These are the vancomycin-resistant enterococci, the MRSA, the Klebsiella, especially the KPC and OXA, Acinetobacter MDR, MDR Pseudomonas, and ESBL Enterobacteriaceae, and the carbapenem-resistant Enterobacteriaceae. So these are the various escape drug-resistant bugs, which we call as the bad bugs for the lungs. So when we look into the history in 1960s, when ampicillin came, the resistance started, the E. coli started developing beta-lactamases. 1980s, cephalosporin started widespread use. There was development of resistance of these bugs, MDR, Klebsiella, Pseudomonas, and E. coli. And in 2000s, extensively we used carbapenems, and now we have the carbapenem-resistant bugs as well. So the carbapenem-resistant strains that we typically encounter now are the Pseudomonas, Acinetobacter, and Enterobacteriaceae. So currently in our Indian ICU settings, the most important bugs which we deal, which are drug resistant, include the MDR Pseudomonas, Acinetobacter, Klebsiella, MRSA, ESBL Enterobacteriaceae, and the CRE organisms. So lack of newer antibiotics definitely threatens the global effort to contain the drug-resistant infections. The classical example was the highly resistant NDM strains. So when we look into the left side of the panel, we can see the development of antibiotic resistance is quite fast, while on the right-hand side, we can see the newer antibiotics which are being introduced in the pipeline, which is very slow. There is a discordance between the introduction of a newer antibiotic versus the development of drug resistance. So why this happens, we all know. It takes a long effort and different phases of clinical trials to get a new antibiotic in the pipeline, while the development of antibiotic resistance can happen super fast. So quickly, without wasting time, I would like to introduce the newer antibiotics which are there in the pipeline. First, I'll be dealing with the oral antibiotics which are there on the left-hand side. And second, I'll be dealing with the most common IV antibiotics for HAP and VAP which are available on the right-hand side. So I'll only deal with the important ones which are already available and being used in the market. The first drug is the lifamulin. It's the oral antibiotic for CAP. The classical trial where lifamulin was compared with moxifloxacin showed that it was non-inferior to moxifloxacin. So what is this lifamulin? It's basically a pleuromucilin antibiotic, which is effective against most of the organisms causing community-acquired pneumonia, like streptococci, H. influenza, and atypical organisms. So the second drug, oral drug, is the omadacycline, which is, again, there is a trial to compare it with moxifloxacin and showed that it was non-inferior to moxifloxacin for treatment of community-acquired pneumonia. What is this omadacycline? It is just an aminomethicillin class of drug, bacteriostatic drug, which acts on 30S ribosomal synthesis, and this is the dosage of the drug. The third drug in the oral medicine in the pipeline, which we already have, is the dilafloxacin. It's a novel fluoroquinolone. Basically, it is effective even against MRSA. That's the advantage of using dilafloxacin over the conventional fluoroquinolones, other than the routine coverage of atypical as well as the gram-positive and negative bugs. So this is the study wherein we compared this drug with moxifloxacin, showing that it was non-inferior, and almost the success rate of Delaflox was 88.9% versus moxiflox, which was 89%. Solithromycin is a fourth generation macrolide, works just like a macrolide. It is effective against all the atypical bugs. The Solitate trial compared it with, again, moxifloxacin and found out that this drug was also non-inferior to moxifloxacin. So this is one drug which we have been using routinely in the last couple of years, that is the cefditorin. This is the novel third generation oral cephalosporin, which is given as 200 mg BD tablets on outpatient basis for those coming with pharyngitis. And for those who are admitted with community-acquired pneumonia, we give double the dosage, 400 mg BD dosage. So what is the advantage of this cefditorin is, this is one antibiotic which doesn't have any resistance to Streptococcus pneumonia, which is the most common bug to cause community-acquired pneumonia. So even the fluoroquinolones, be it the oral cephalosporins like cefuroxime, cefpodoxime, or be it the other macrolides, all of these have started to develop, kind of resistance. The streptococci has developed resistance, but cefditorin, no resistance has been yet determined. And when we look into the potency of this drug against streptococcal pneumonia, we see that it is 3 times more potent than cefpodoxime, 4 to 8 times more potent than cefuroxime, and 16 to 32 times more potent than cefixime. Other than this, it covers most of the other bugs which are responsible for causing community-acquired pneumonia. So the profile of this cefditorin is almost comparable to IV cefotaxime, but only thing is we are giving this as an oral drug. So this is the trial where cefditorin was compared with levofloxacin for acute exacerbation of chronic bronchitis, wherein we found out that the clinical cure rate was 80% with cefditorin drug, while it was 75% in the levoflox arm. Cefditorin was also compared with the other commonly used cephalosporin, that is cefuroxime, in acute exacerbation of chronic bronchitis, and found out that the success rate of both the drugs was quite similar, but the duration of therapy could be reduced to half by giving cefditorin, that is 5 days course versus a 10 days course of cefuroxime. So the recommendation for cefditorin includes, it has a good gram-positive and negative activity with high potency against streptococcal pneumonia strain. It is also useful when you're switching from parenteral to oral therapy, like, you're discharging the patient on oral antibiotic. So this is the most appropriate therapy so far. The other IV antibiotics in the pipeline, we have the 5th generation cephalosporins. One is the ceftaroline. Ceftaroline has most of the potency against all the community-acquired pneumonia bugs and high affinity for MRSA. These are the meta-analysis trials where ceftaroline was compared with the other drug, that is ceftriaxone, for treatment of community-acquired pneumonia, and found out that it was far superior to ceftriaxone when it comes to treating adult patients with community-acquired pneumonia as an empirical therapy. Ceftobiprole is another 5th generation novel cephalosporin, which basically has significant activity against gram-positive and negative bugs, including those like Klebsiella, Pseudomonas, and E. coli. It is also effective against VRSA, but it has limited activity against Acinetobacter. So we mainly use it for treatment of CAP and HAP, but we don't use it for ventilator-associated pneumonia. So this is the trial wherein we looked into the ceftobiprole versus ceftazidime plus linezolid for the treatment of hospital-acquired pneumonia, and found out that ceftobiprole was safe and effective bactericidal antibiotic for empirical treatment of HAP, but not for the treatment of ventilatory-associated pneumonia. Coming to the next drug, that is tedizolid. Tedizolid is just a congener of linezolid. Why it is important? Because there are some strains which are even resistant to linezolid. Certain MRSA strains which are resistant to linezolid, they responded better with tedizolid. So this is the trial wherein we looked at the tedizolid versus linezolid for treating the ventilated gram-positive nosocomial pneumonia. And it found out that the efficacy was non-inferior to linezolid, and it was well tolerated with minimal side effects as compared to linezolid. The next drug, which is very important, which I need to highlight a lot, because this is the drug which has been in the pipe, it has been recommended by the recent IDSA 2023 guidelines for most of the MDR bugs, that is the cefiderocol. So cefiderocol has got a novel mechanism of action because it binds to the ferric iron and is actually transported inside the cell membrane by the transporters, and there it exerts its effect. It has been found to have a very good activity against the ESBL Enterobacteriaceae, the CRE bugs, the meropenem-resistant Pseudomonas, that is the MDR Pseudomonas, Stenotrophomonas, Maltophilia, and even against Acinetobacter baumannii. So this drug, there are a lot of trials to say that it can be used in most of the MDR bugs, including HAP and VAP patients. The next drug we have is the ceftolozane tazobactam. Again, it's a novel cephalosporin with a beta-lactamase inhibitor, wherein most of the, again, CRE organisms, the ESBL Enterobacteriaceae, and the gram-negative bugs can be ceftolozane tazobactam. So this was a trial wherein we looked at ceftolozane tazobactam versus the commonly used drug, that is meropenem, and found out that high dose of ceftolozane tazobactam was efficacious and well tolerated for most of the gram-negative hospital-acquired pneumonia, and even in mechanically ventilated patients and critically ill populations. The most commonly and the most popular drug that we have currently in the market is ceftazidime avibactam. So ceftazidime avibactam, we all have been using it. So this is a newly developed beta-lactamase inhibitor, which is avibactam. We all know that avibactam has a wide range of beta-lactamase coverage. It has a significant effective in vitro activity against the CRE organisms, the ESBL Enterobacteriaceae, and Pseudomonas. But what is important to note and understand here is this drug, that is ceftazidime avibactam, which we popularly call as Zavicefta brand, this is a drug which is not very effective against Acinetobacter and including MRSA. So this has to be used in caution in those group of patients where there is a risk factor for Acinetobacter. So this is the trial of ceftazidime avibactam when compared with meropenem for treatment of hospital-acquired and ventilatory-associated pneumonia, where it found out that this provides a very new treatment option for both HAP and VAP patients, and including, more importantly to understand, is those where there was resistance to ceftazidime. Ceftazidime avibactam was effective even in those category of patients. So where does Zavicefta stands or holds a role? So this drug for a pulmonologist holds a role in hospital-acquired pneumonia, including ventilatory-associated pneumonia, caused by most of the gram-negative bugs, including Enterobacteriaceae, Klebsiella, Serratia, and Pseudomonas. So, but what is important to note here is what bugs are not effective for ceftazidime avibactam. One is MRSA, second is anaerobes and Acinetobacter species. So if you are suspecting any of these, you will have to add one more antibiotic or don't use this antibiotic. Again, the efficacy of ceftazidime avibactam was near to colistin for most of the bugs that was used in the clinical practice. So what is the patient profile wherein you are supposed to choose this drug or ceftazidime avibactam is patient with nosocomial pneumonia, complicated UTI, complicated intra-abdominal infections, critically ill patients in ICU. Whenever there is risk factor for CRE or ESBL enterobacteriaceae, you have to use this kind of drugs. Critically ill patients, please use this drug, but not to be used if there is MRSA, if there is Acinetobacter, or if anaerobes is the predominant culprit. The next drug we have, which is again having a very good efficacy against most of the MDR bugs, is the meropenem-vaborbactam combination. So this combination has a significant effect because it reduces the MIC of meropenem by more than 16-fold against Enterobacteriaceae. So this drug, we have a trial wherein this combination was compared with the best available treatment for carbapenem-resistant Enterobacteriaceae. The Stango 2 trial basically looked into this part and found out that compared to the best available therapy for the carbapenem-resistant Enterobacteriaceae, monotherapy with meropenem-vaborbactam was having a significant effect in reducing the mortality and getting a high cure rate. The other drug we have is imipenem-relebactam combination. Again, a novel non-beta-lactam beta-lactamase inhibitor has been added to imipenem. The advantage here is those which are resistant to imipenem can respond even to imipenem-relebactam combination. Similar is the combination of avibactam to aztreonam. So aztreonam-avibactam combination has significant in vitro activity against ESBL and KPC producing strains and limited activity again against Acinetobacter and Pseudomonas. Ceftaroline-avibactam combination, a novel 5th generation cephalosporin, has been added with avibactam. This combination actually helps us to treat it, give a good efficacy treatment in the patients with ventilatory associated pneumonia. So to summarize my talk, I would like to say that resistant strains pose a major threat in clinical practice because of the lack of significant therapeutic options for them. Several newer antibiotics have been recently approved or in the stage of the development. They have broad spectrum activity against the MDR pathogens, in particular the ESBL enterobacteriaceae, the CRE organisms, the MDR Acinetobacter and NDM1 strains. For community-acquired pneumonia, the newer oral antibiotics we have include the lifamulin, delafloxacin, and cefditorin, which is being widely used currently. For MDR Acinetobacter, we have drugs including cefiderocol, which is the most potent drug and recommended by IDSA in most of the situations, ceftaroline for MRSA, ceftaroline avibactam for VRSA and MDR Acinetobacter, and the newer drugs for MDR bugs like meropenem-vaborbactam, imipenem-relebactam, and of course, we are combining cefepime now with zidibactam and ceftibuten with clavulanate. Thank you for your attention and time.
So, thank you, Sachin, for that. You've given us a list of tongue twisters. I am already, bad with the ones that we already have. And God forbid, in the times to come, I think the list is growing. And I think it is very, very important because you need to stop sharing the screen. Because as the bugs become more resistant, we need more newer antibiotics. So thank you for that. I think you've done a fantastic job in covering all the newer antibiotics. And when we come to the panel discussion, we'll actually be taking case-based approach as to what to do when you have a patient with VAP, what to do when you have a patient with AECOPD, or someone with an acute exacerbation of bronchiectasis. But that said, a job very well done because you've summarized all the newer kids on the block. And because I think in the times to come, next couple of years, as become with ceftazidime avibactam or with cefditorin, we would be actually exposed to a lot of these antibiotics. So it is important for us pulmonologists to understand when and where to use these antibiotics rationally. So thank you, Sachin. We'll come back to the discussion with you later. So the next talk is again a very contemporary and a very important topic, and this is on the interpretation of the multiplex PCRs, and this is something which has come up in a big way in the last couple of years. All of us have been bogged down. A lot of information keeps circulating on this. However, I do believe that there is a lot of gray zone, and we still don't understand how to interpret these reports properly and what to do next. So to do the honors, I have with me Dr. Saurabh Mittal. Saurabh has been trained at AIIMS New Delhi and currently works there as an assistant professor. And Saurabh would be talking on multiplex PCR, the current role and interpretation. Over to you, Saurabh.
Good evening, everyone. Thank you, sir. So, after listening to the antibiotics, I'll talk a little bit about microbiology, that how do we interpret and where do we place the role of multiplex PCRs, which are a common thing in today's scenario of respiratory infections. So, so we see LRTIs, as we have seen, are a leading cause of mortality and morbidity. And the problem with the most of such diagnosis is that we tend to give a lot of empirical antibiotics, which will lead to overuse of antibiotics. And we need to have something which will lead to a pathogen-specific therapy. So the current methods which we use for the diagnosis are, which are the culture-based primarily, are slow, and many times they fail to identify a causative organisms in patients with low respiratory tract infections. So we need to treat patients empirically, and a lot of broad spectrum antibiotics are being used, which leads to drug resistant emergence. So how can we really overcome this? So I have a case, and then we'll take this case forward and see how it can be applied to our clinical practice. So we have a 70-year-old male, a man who is a smoker with uncontrolled diabetes, who had a recent hospitalization for urinary tract infection, and now had presented with shortness of breath, cough, and high-grade fever for 10 days. On examination, he had tachycardia, tachypnea, hypoxemia, and hypotension. So a diagnosis of severe pneumonia with a type 1 respiratory failure was made. He was intubated and started on broad-spectrum antibiotic, that is piperacillin, tazobactam, and levofloxacin. After 4 days of ICU stay, his ventilator requirements increased, and there was increase in the volume and purulence of secretions, and there were new non-resolving opacities on the chest radiograph. So the ET aspirate, which was sent at this point of time, showed more than 3 gram-negative baseline as grown. A web diagnosis was suspected, and antibiotics were changed to meropenem, and levofloxacin was continued. This is a common scenario in a lot of ICUs where after 4 or 5 days of stay, we suspect development of ventilator-associated pneumonia. A repeat culture was sent to culture the dominant colony. 2 days later, the patient had worsening respiratory failure along with shock and sepsis, AKI, and he succumbed to his illness on day 6. And on day 6, we got the ET culture report, which showed Klebsiella pneumoniae, which was actually resistant to the antibiotic which were being used, that is the imipenem or meropenem, that is a carbapenem. Now, this is a common scenario for ICUs where culture-based approach is used for treatment of ICU-acquired infections. So now the question comes, could the diagnosis have been achieved earlier in this patient, and could we have done something better to save this patient? And that's where the role of point-of-care tests or the molecular-based techniques for ICU infection comes in play. So if you look at the diagnostic techniques for ICU infections, we have conventional methods like microbiology, culture. Now we have antigens, some serology, molecular testing, and imaging. So all of these need to be put into the correct perspective to reach a correct diagnosis and correct organism. The traditional methods, which are basically based on plating and culture and antibiotic susceptibility, but we need to accept that we need new technology, and we need to start embracing this new technology so that we can improve our diagnostic abilities. So once we look at the molecular diagnostics, it has pros and cons. There are some goods and bads about like any technology. So what are the pros of a molecular diagnostic method? It has a rapid turnaround time. It gives early diagnosis and saving the time for initiation of treatment. The results of a molecular test are usually not affected by prior antibiotic use. It helps to identify difficult to culture organisms such as viruses. It reduces the manpower, human error, and the cost which is required in long run. At one point of time, it may look it is costly test, but in long run, it will actually save the cost. The organisms which require prolonged time for incubation, such as Mycobacterium tuberculosis or NTMs, are rapidly identified by molecular diagnostics. And one very important thing that it helps in identification of the resistance strains by having determination of resistance determining genes. What are the problems with these technologies? One is test inhibition. So if you have sample like a stool or a blood, then they contain substances that interfere with molecular reactions and may lead to false negative test results. Sometimes you may get a clinically irrelevant result. That is, we identify some genetic material on a molecular test, but the presence of genetic material alone does not clinically have a relevance if it is a colonizer or a dead organism. And obviously, these tests do have an initial cost investment, which may or may not be feasible for a lot of centers or hospitals. So these are some pros and cons of adapting a molecular diagnostic setup in your ICU or a difficult pneumonia infections. So if you look at the conventional PCR, it has sample collection, then transportation, sample goes to lab, then nucleic acid is extracted, PCR is done, and then reporting is done. This takes some time. So that's where the conventional PCR-based methods have now evolved into multiplex PCR methods. Multiplex PCR means it is works on the same principle that nucleic acid purification is done, then complementary DNA is formed. But the point is that this multiplex PCR has a lot of amplicons which need to be amplified. So it puts up the probes for various organisms which are common, and in one PCR go, you can actually identify multiple organisms if there are any. So that's the basic purpose of multiplex PCR. Multiplex PCRs are basically of two types. Some are the commercially available and some are in-house multiplex PCR. In-house are that a lot of Indian labs also have made their own multiplex PCR panels. Uh, However, there are some differences between the two, which I will discuss, that what is the standard and what are the in-house multiplex PCR tests. So this was one of the early study which actually looked at the utility of multiplex testing for rapid diagnosis of infection in critically ill. It was a multi-center study of molecular detection in bloodstream infections, pneumonia, as well as sterile site infection. So in this 616 bloodstream infections, 185 pneumonia and 110 sterile fluid and tissue specimens were taken for 529 patients. If you see, molecular tests found an organism in 37%, while culture found it in 11%. So there is a grossly increased number of specimens which are found to have a microorganism. And by this reaction, this PCR-based test had a sensitivity of 81% and specificity of 69%. And the primary utility was that the ability to rule out infection within 6 hours was found, and it had a potential clinical and economic benefits. So there have been multiple studies like this based upon different specimens, which have shown that we can increase our organism detection and may be able to reduce the antibiotic usage during ICU. But there are some problems with this. And for this paper, we had written a letter that just, and this is a very important thing, that just mere detection of microbial DNA in blood is true or false positive remains unclear. There have been instances where organisms have been identified, but it is actually not a true infection causing organism. So the results of these molecular tests need to be interpreted in proper clinical context. However, over last couple of decades or years, what has actually happened that these tests have also become better and evolved, and now they actually focus on the pathogenic organisms rather than the previous ones where they used to do a lot of sequencing and identify organisms which were actually not pathogenic. So this was a systematic review and meta-analysis of a effect of molecular rapid diagnostic testing system on clinical outcome in bloodstream infections. And they found actually that the mortality risk was significantly lower if a molecular rapid diagnostic testing was used than the conventional microbiology methods. Also, use of a rapid diagnostic testing system led to improved time to effective therapy, which was decreased by nearly 7. So I think this 5 hours difference is important. If you already have a system where you are very effectively using your conventional methods and you are very rapidly changing your treatment decisions based on your microbiology, this system can actually improve your efficacy and improve your antibiotic usage. So now we just talk a little bit about what this technology is. So primary technology is called as the film array or the FA system. It has a combination of gram positive, gram negative, some fungi, and some antimicrobial resistance genes, which can be identified on a single assay. It is approved for many body fluids. We'll see there are multiple panels available for testing. It is multiplex qPCR, in which there is nucleic acid extraction and there is two-stage PCR. So we have seen that how does a BioFire is a brand name or one of the common used FDA approved multiplex PCR test, which is being used in a lot of hospitals as compared to the in-house multiplex PCR test. So it is a pouch-based test in which you put the sample and the results are available. So the point of a multiplex PCR, which is BioFire, it has hands-on time of approximately 2 minutes. That means human work is only for 2 minutes and runaround time is around 1 hour. So it has fast and accurate result. It has a comprehensive panel. So you have to focus it here that RP means respiratory panel in which there are 22 targets, which are predominantly the viral targets. Then we have pneumonia panel, which has 34 targets. The blood culture has 43 targets. GI has 22 targets, and meningoencephalitis has 14 targets. So there are different types of panels available with the BioFire multiplex PCR based upon which type of infection are you dealing with and what sample you subject to the testing. Molecular diagnostics is associated with increased sensitivity. So like we see, this is the blood culture identification panel, which has 43 targets. This is the pneumonia panel, which we will discuss in detail. And this is the meningitis panel, which has 14 targets. So the first panel I'm going to talk a little bit about is the respiratory 2.1 panel. This is a predominantly a viral panel for upper respiratory infections. So most of the organisms which are covered in this are the viruses which are common causes of the respiratory infections. There are some bacteria such as Bordetella pertussis, Bordetella parapertussis, Chlamydia, and Mycoplasma, which are also covered on this panel. So the sample taken for this panel is nasopharyngeal swab transport media, and the test has a 97% sensitivity and 99% specificity. So what is the primary use of a respiratory panel is most often used in emergency rooms where you have a patient with acute respiratory illness. You take the sample of nasopharyngeal swab, send it for the lab, and you identify the exact organism, and you may be able to decide the treatment plan based upon your respiratory panel. And it has been shown that specifically in children, use of respiratory panel actually leads to reduced use of antibiotics, because if you identify a viral organism as a cause of URI or a respiratory illness in a child, you may be able to reduce your antibiotic usage. However, this respiratory panel is not done in all hospitals, and some labs also offer their own respiratory panels as an in-house multiplex PCR. The other panel is the pneumonia panel. Pneumonia panel you can subject samples such as sputum, endotracheal aspirate, bronchoalveolar lavage, or a mini. So it has multiple organisms which it covers. The sensitivity is 96% and specificity is 98%. The commercial name of this panel is BioFire Film Array Pneumonia Plus Panel. So this is the Pneumonia Plus panel. It has 15 bacteria, which are the common pneumonia organism causing bacteria. It has 3 atypical bacteria, that is the Chlamydia, Legionella, and Mycoplasma. It has 8 viruses, and it has 7 antimicrobial resistance genes. So with this one panel, you are able to identify the common bacteria, atypical bacteria, common viruses, as well as if you identify any of the bacteria, then you can also find if there is a resistance gene which is there. So this pneumonia panel is most often used for ICU patients for hospital-acquired or community-acquired infections to identify and for the appropriate antibiotic therapy for these patients. So we have seen how does a multiplex PCR actually works. This is a sample report for a multiplex PCR for our patient. So this is, if you see it here, this is a BioFire test. It is a pneumonia panel plus. So on the first, you can see there are multiple organisms. So this report has 2 organisms which have been found. One is the Acinetobacter and another is the Klebsiella pneumoniae. And on the right side of the slides, you can see the bin or the copies per ml which have been identified. It gives you the more than 10 to power 7 copies as Acinetobacter and Klebsiella, and the result is given as that these two organisms are detected. So this reports organism concentration in genome copies per ml. Now, what is next is that it tells you if you have any atypical bacteria, which is not detected, if you have any virus, which is also not detected, and once you have identified the two organisms, what are the resistance genes? So one is so like in this, we have the CTXM gene, which has been detected, and OXA48 like gene has been detected. So there are 8 antibiotic resistance genes which a biofire panel can give you. So how do we decide treatment based on this? So this is a general guide if you identify a resistance gene. Like for CTXM, it gives that resistance to cefotaxime, ceftazidime, aztreonam, and ceftriaxone. If you have IMP positive, that means there is resistance to imipenem. For KPC, this is the Klebsiella pneumoniae, which is resistant to carbapenems. For NDM, we need to use colistin and sometimes 3-decycline or aztreonam can be used, or newer antibiotics, as Sachin mentioned in his presentation. For OXA48, ceftazidime avibactam can be used, or multiple combination regimen for other antibiotics can also be used. For Vim resistance, that there is resistance to 4 antibiotics, that is cefotaxime, cefazolin, ceftazidime, and kanamycin. So this is the primary use of using this resistance testing for identifying. One resistance here is for the MRSA, that is by the MAC-AC and MREJ gene. So if you identify as Staphylococcus aureus, then resistance for methicillin can be based on mutation in this gene. So this tells you about MRSA as well, along with multiple other resistance based upon the molecular testing. So this was a study which looked at the clinical evaluation and potential impact of semi-quantitative multiplex molecular assay for the identification of pathogenic bacteria and viruses in lower respiratory specimens. So in which 259 BAL specimens were collected and they were tested using this pneumonia panel as compared to the standard of care. There was a 96.2% positive percent agreement and 97.6 negative percent agreement between PCR and culture. This film-array test detected a bacterial target in 71% more BAL specimen than routine culture. And there was a potential antibiotic adjustment in 68% of patients 3 to 4 days earlier. And probably this is one of the most important things which we have to focus upon, that this test may help us in discontinuation or but earlier this de-escalation of therapy. Like 48% of the patients, there was an appropriate de-escalation of antibiotic based upon the resistance pattern identified by the biofire testing. How is biofire, which is the commercially available test, different from the third-party assay or the in-house assay? The in-house assay are usually open PCR and there are chances of manual error and there are chances of contamination, while biofire film array is a closed system. Third parties assay have limited number of targets, while the biofire has higher number of targets, has a smaller turnaround time as compared to third party assay, which have more third party assay. Also important thing is that biofire assay is FDA approved because of the proper validation, while the third party assays are locally validated. It depends upon the quality of the lab which uses these assays, so that that we can kind of trust these labs whether they are doing the appropriate testing. So this is all from my side. So I would just like to summarize my talk that molecular methods do help us achieve early diagnosis with greater sensitivity of detection of all microbes. However, being highly sensitive, it is important to interpret the positive results along with the clinical context. It is very important to have an antimicrobial stewardship program, and results of these assays should be used to direct the appropriate therapy. And not all molecular methods are validated, and discrepancies with existing standard of care tests should be interpreted with the caution for better patient outcomes. That's all from my side. Thank you for your patience.
Thank you, Saurabh, for summarizing that so well. This is always, it's a very contemporary topic, and interpretation does come with a lot of, there are various gray zones there. And thank you for summarizing it so well and for making it so simple. And I've already got so many questions that have been posted by the audience today. So the panelists, I have all my 5 panelists here. So you're all in for a lot of questions. So we'll keep it very brief as there is not much time left. And the questions would be random. I've got questions for both the topics. I've got questions for PCR. I've got newer antibiotics, a lot of contemporary and related, clinical questions which are related to management or infective diseases. So I'll start with Professor Pervez Kaul. Good evening, sir.
Good evening, Arjun.
We just heard sort of talking about multiplex PCR. So what is the ideal sample for doing this multiplex PCR? We do see a lot of these companies telling us that you can actually do a throat swab and, you can just check for the viruses there. You think a BAL, a mini BAL or invasive sampling is required, or a throat swab is good enough for a multiplex PCR?
So Arjun, a very quick recap. You must understand that if we talk of the guidelines, still the guidelines on the community acquired pneumonia do not recommend a routine diagnosis by way of these rapid microbiological techniques. However, the latest ERS ESICM guidelines about the management of severe community acquired pneumonia did mention that whenever technology is available, we must use a lower respiratory tract sample, either in the form of a sputum sample or induced sputum, or an endotracheal aspirate, or a bulbs or a mini bulb sample. Which is a better sample? I would suggest that a lower respiratory tract sample obtained in a more aseptic manner would be a better sample. So probably from the lower respiratory tract by way of a BAL or a mini BAL, because there is a greater chance of contamination in the upper respiratory tract, which would be giving you false targets, false organisms, and that's why I would suggest that if and when we require to go for testing for this, generally in sick patients, then probably lower respiratory tract samples would be better.
Sir, point very well taken. Nitin sir was talking about, targets, and we are getting multiple reports where, unfortunately with these tests, as it is a PCR based test, so you get multiple bugs turning out to be positive. So how do you choose the right bugs? Which one to target actually? How do you choose that?
Yeah, I think it's a clinical decision rather than whatever is thrown at you. The classic example is, just now we had a person who's been chronically infected, and he had a culture-proven drug-resistant Klebsiella, and we in any case had to do a bronchoscopy for another suspected diagnosis, and he also showed coronavirus as well as Haemophilus influenzae. Now, which of them are you going to treat? So we just continue treating the coronavirus in general, coming from the lower respiratory tract in today's context, had no meaning. So it's not going to be relevant. So I think one has to take it with a pinch of salt. That's one. That whatever reports are thrown at you, you don't treat the report, you treat the patient. And the patient was suffering from a purulent sputum for a very long time. He needed nebulized colistin for that matter, because it was a drug-resistant organism. And the nebulized colistin with tigecycline was, because tigecycline was sensitive on the culture. So we continued with that. Tigecycline in any case was going to cover the Haemophilus influenza, so that was not a problem. And coronavirus was ignored. So I think that sort of, in a nutshell, puts the whole story in a simplest way, that just do not look at the report for the sake of doing it. Of course, you might sometimes land up doing more tests in a desperate situation, but take them with a pinch of salt. Use your clinical acumen, use the clinical story behind the clinical context, as is very importantly stressed by the previous speakers. The clinical context is most important. You can't just randomly go on treating everything that is thrown at you.
Rosa, point very well taken. And sort of coming back to you, a lot of these, just not only do they tell us about the bug, but as you very rightly said, they also tell us about the antibiotic resistance patterns. So how seriously are we supposed to take them? Because very often, clinically, you see there is a discordance, and the culture reports would tell you some kind of a difference resistance pattern, and the mutations that you would get on a multiplex PCR would be different. So how to interpret these mutations? Obviously, we all understand that the conventional cultures are always better, and the mutations that you get on a conventional culture are better. But do you take the these mutations that you get on a multiplex PCR, do you take them seriously, or, what is the clinical relevance of these mutations?
So I think, sir, one before I answer your question, I would like to make one thing clear is that the potential utility of such test is predominantly for the pneumonia panel is predominantly for the ICU infections. For patients where we have like it's not just for the outdoor patient who is coming to you, or so that is not predominantly it's for the most useful is in the ICU acquired infections. Number two is the whether we can actually rely on the antibiotic resistance. So, as you rightly said, that the conventional culture methods are always better and good. The point is that if you have supposedly your conventional culture shows that the drug is sensitive, however, your molecular tests show that it is not sensitive, I would always believe my conventional culture, but I would always keep it in mind that my molecular test has shown. So there might be some resistance genes which are still there. However, the dominant organism or dominant colony of the organism may be sensitive. So I always keep that in mind while I'm treating my patient that if there is any suspicion, I would change my treatment based upon my panel. Secondly, there are times when your molecular test will not detect resistance, while your phenotypic testing will tell you that it is resistance. In that case, the phenotypic testing has to be taken into account. The role of molecular test is as an additional tool to guide your treatment. The conventional cultures are here to stay because that's the kind of a visible evidence to your eyes that yes, this drug is kind of killing the bacteria on the plate or the cultured media. So they are going to stay here, but this kind of adds to your clinical acumen that yes, I have this organism which has been identified. So if my patient is not getting better, I would preferably change my antibiotics.
Point very well taken. And Sachin, this is a question for you. A lot of times, in the ICUs, there's this question about, if a patient comes to you with, say, a community-acquired pneumonia, or someone who has a hospital-acquired infection, someone who's in the ICU. And there's always this conflict when to start gram-positive coverage. For most of us, if someone's sick and in the ICU, it would probably be a combination of something like meropenem with, say, doxycycline, or, one of these combinations. And we would usually not start them on gram-positive bugs, to say. So what is your take on starting empirical gram-positive therapy? When should one do it?
So, whenever it comes to gram-positive bugs, most of the antibiotics that we will be giving in our ICU settings, they cover most of the gram-positive bugs, unless, there is a resistant gram-positive organism. So, mostly we are dealing here with, MRSA. So, MRSA is something that, we always are concerned in the ICU settings. Whether to add an MRSA coverage or not empirically becomes a big question. So there are IDSA has given clear-cut guidelines as to when you are supposed to start an empirical gram-positive cover, that is especially for MRSA cover. So they say that, if the person has been in a close contact with an MRSA carrier, or if the person is suffering from a post-influenza pneumonia, where there is a high risk of getting MRSA, or if the person is in a military recruit or a prisoner, or if there is multiple lines, he's on dialysis, hemodialysis, or if the patient suppose is having an IV drug abuse history, or if there is an MSM history. So these are the clear-cut indications wherein an empirical gram-positive MRSA cover can be added as a frontline therapy for these kind of patients. But otherwise, for most of the other patients, we do wait till if the patient is clinically recovering and if there is no risk factors for MRSA. I think we do not have to start an empirical MRSA cover for most of these patients.
Sure. Thanks for summarizing it so well. The next question has been asked to Atri. So Atri, acute exacerbation of COPD is something that a pulmonologist would always encounter. What is your take on antibiotics in an acute exacerbation of COPD? When in an AE COPD should you give antibiotics? And what is your take on, what is the rationale or what is your step up, step down of antibiotics? What is it that you usually start with in a patient who has a mild exacerbation vis-a-vis someone who lands up on the ventilator? And any role of the newer antibiotics like cefditorin that Sachin was talking about in these situations? What is your clinical experience with this antibiotic? Would you want to start this upfront in people who have AECOPDs or who land up on the ventilator?
Yeah. Thank you for having me here. Not very long ago, Dr. Arjun was the examiner and I was a PG student, and now we are in a panel. That's really wonderful. Acute exacerbation in India, it may start as a viral, it may start due to missing medicines, it may start due to air pollution, but often it ends up into bacterial. If the patient does not have a very long COPD history, let's say less than 2 years, good spirometry, good lung function, that person, we may classify it as a mild exacerbation and not give an antibiotic. Purulent sputum, high fever 2 consecutive days, unstable BP, please consider antibiotic, better safe than sorry. Procalcitonin is a wonderful blood test. It may be costly, but if you look at the cost of missing out antibiotic and patient deteriorating, so in that OPD level also, procalcitonin can be a good test to decide my decision to take antibiotic. Again, if I want to start antibiotic, earlier history less than 2 years, I would consider it a community acquired. I may want to start with a amoxicillin as per guideline. Unfortunately, thanks to WhatsApp University, patients come and tell me, we have tried amoxicillin, we have tried azithromycin, we have tried ciprofloxacin. Then maybe I am forced with some cefpodoxim, cefixim. Recently, while encountering these patients, I was forced to start cefditoren because I came to know about it recently. And I found cefditoren has not been used too much. And it's a wonderful oral counterpart. Otherwise, we may have to give IV cefepime, cefoperazone. So their oral cefditoren, OPD setting, no need for admission, 200 mg BD 5 days helps me. If the patient lands up in ventilator on day one, on admission, then it's a polymicrobial therapy. I would want to start with a extended spectrum cephalosporin, where ceftazidime, avibactam, if a prior antibiotic use, along with a combination of either colistin or a quinolone, respiratory quinolone, levofloxacin, moxifloxacin.
So I think, yeah, it has to be a stepwise approach. Obviously, in an ACOPD, antibiotics are not for all. But if you have to use them, you would try to use with the mildest. Unfortunately, as you very rightly said, a lot of people do come to us already having taken antibiotics. So yeah, we at times are hard pressed and we have to sometimes use the higher molecules. Thanks for that. So this question is for, I think Professor Pervez Kaul would be the best to take this. So pulmonologist, when we are given an antibiotic sensitivity report to interpret, a lot of these would come with the MIC values, breakthrough points, and I think most of us get boggled by these values and don't know how to interpret them well. So what is your message to the pulmonology community? Should we be looking at these MIC values? How do we interpret them? And how should a pulmonologist actually take this report forward? How do we utilize these MIC values and breakthrough points in our clinical practice?
Arjun, that's a tough one because the answer is not uniform to most of the practicing pulmonologists. It's very important to understand the setting that we are working in. And most of us may not have access to these Vitek system generated MIC values. But the general cultures that used to give us breakpoints that it would be called at sensitive, intermediate, or resistant, and that would be a useful reference for us to understand as to which antibiotic probably is not to be given and which antibiotic is to be given the clinical context of the condition that we are actually aiming to treat. So should we, now that we are blessed to have these MIC values specifically for people who are working in tertiary care centers, they are of help, certainly. I would not say they're useless. But in the context of the patients that generally pulmonologists see, if we say that pulmonologists see pneumonia patients, in the context of pneumonia patients, generally MICs are not of a great help. However, there are certain situations when MIC can be useful because we also do treat patients in the intensive care units. These are patients where we have the bacterial resistance when an alternative to the reference treatment is required or used, like ESBLs, carbapenemases. A patient has a meningeal infection and you are considering an infection by a beta-lactam resistant, say, streptomycin or H. influenzae. So then there may be patients with augmented renal clearance, for example, vancomycin and if you have a drug which has a narrow therapeutic window, like you are using glycopeptides, you're using aminoglycosides. So yes, there is a role for MICs, but in general, if you look at pneumonias, I would not routinely look at MIC values. the usual breakpoint of resistant, intermediate, and sensitive given by our routine microbiologist is good enough for us. But however, if you have MICs available with you, they would be helpful, but not necessary.
All right. So point very well taken, sir. So changing gears, questions for Dr. Nitin. So people are saying that VAP is a common clinical problem and VAP is something that still continues to boggle us. So 2023 management of VAP, where are we? Why is the mortality still so high? What is in your clinical practice? What is the antibiotic regimen that you would start with in your ICU? And is there any role of nebulized antibiotics in the management of VAP? So 3 questions from you, quick comments on 3 of the points.
Yeah. I think you have asked me the 3 most difficult questions, because most of the times I am failing to find out the answers to all these 3 questions. The most, if you really ask us what in a VAP setting, if it is a VAP with a which may have early VAP, as you would say, rather than a late VAP, then I'm still comfortable starting, say, something like not sulforazone sulbactam, but Zosine, which is piperacillin tazobactam. So even that, along with some additional antibiotic, is good enough. But if it is a late VAP, and I know that the antibiogram in my hospital is dominated by drug-resistant Pseudomonas and drug-resistant Klebsiella, then, for example, Zylsepta becomes possibly the best choices in the late VAP kind of scenario. So I think it depends on time to time, what kind of a clinical gravity, what rapidity, all those things have to be taken into consideration. And you also have to know the antibiogram of the hospital, and some kind of a policy has to be there. Mine is an open policy hospital. It's not mandatory that everybody sticks to a particular antibiotic, but there is some rationale and there is some to and fro discussion between us and the microbiologist and the hospital administration as well, because you have to look at, for example, an Acinetobacter outbreak. Most of the time it's an imported outbreak. I mean, the infection comes into one patient who comes from outside, but then another 3 or 4 patients can be infected, and therefore the administration also has to be sensitized as soon as you have a bug like Acinetobacter in the hospital for some reason or the other. So I think all these things have to be kept in mind. I'll come to the last question, and I have some insights on this because I have been using nebulized antibiotics extensively. But they are largely, the nebulized antibiotics I have been using have been more outside than inside in the hospitals. Very much limited usage and generally a concomitant usage. For example, if I'm using colistin to treat a bad VAP, and I'm using colistin in conjunction, it makes sense, no problem. Once in a while, you will find a patient who is, for example, I have a story. I'll just, if you allow me 1 minute, I have a doctor who was lobectomized about 50 years ago. He is a bronchiectasis patient. He was chronically colonized by completely drug-resistant Pseudomonas, was only sensitive to colistin. And 5 years hence, he was on non-invasive ventilator, was left to die at home. He's been on 15 days off, 15 days on colistin, 1 billion units every 8 hourly for last 5 years. And over a period of time, this gentleman is a miracle worker. Rather than me, he's the one who is the miracle worker. He eventually became, more or less that got eliminated. And now the bug that he has is tobramycin sensitive. And now he's back onto the tobramycin nebulizations instead of colistin nebulization. So 3 years it took them. Now last 2 years he's taking these 2, and he's still colonized. The colonization has not gone away. So that is another important issue in respiratory practice, that a lot of people will remain colonized. That infection will come up if you do not suppress it. And that is where the real beauty of nebulized antibiotics is. We don't have so much cystic fibrosis, but we have a lot of non-cystic fibrosis, bronchiectasis, which it easily colonizes, and not just colonizes, but becomes a bear bug for future recurrent exacerbations. This gentleman, who was in and out of the ICU, practically left to die, has not got admitted even once in a year over the last 5 years. So that is the story of a well-targeted nebulized antibiotic. But in the ICU settings, I very, very sparingly use it, and I use it mainly as a concomitant therapy rather than a isolated singlet therapy of a nebulized antibiotic as a curative therapy. So it is along with an intravenous preparation that I will use this. I
Sure,
hope
sir.
the others agree or disagree, whatever it is.
Absolutely,
I would
sir.
like to learn.
It has to be in combination always. And I think role of aminoglycosides in the nebulized form is something that is coming up in a big way, and everyone is talking about that.
Yeah.
So thank you so much for that. So going to Sachin. Sachin, ceftazidime avibactam is something you talked about. When do you use it in isolation? When do you combine it with aztreonam? Because you will see a lot of industry people coming to us and telling us that it has to be used with aztreonam in certain settings. What are those clinical settings where you would use ceftazidime with avibactam, and when would you use it in combination with aztreonam?
So I think this is one thing which always, we deal with, whenever we are using ceftazidime avibactam. So we usually prefer it to give it for the complicated HAP and VAP patients, but when to combine it with aztreonam becomes a big question. So usually in our setting, in our critical ICUs, when we combine is whenever we are starting an empirical therapy for a person who has risk factor for CRE infection. So these are the group of patients we start empirically on dual antibiotics. We want to cover 2 gram-negative bugs. So we start them on ceftazidime, avibactam, aztreonam. But as per the IDSA recommendation, as early as possible, once the culture report comes, we need to de-escalate the antibiotic and make it a single monotherapy. So we also try to follow it in our ICU. So as soon as the culture report comes and it says that it is sensitive to maybe ceftazidime, avibactam, we have the discs available for Zavicefta. So once it says that it is sensitive, then we withdraw the aztreonam and probably we give only monotherapy with ceftazidime, avibactam. So we do not continue this dual therapy for quite long. So it's only reserved in certain critically ill patients wherein as an empirical therapy, we recommend it where we have the risk factor for CRE bugs.
All right. And Saurabh, coming back to you. So Sachin has been talking about these VREs, CREs, and on a multiplex PCR report, you do get to see a lot of these, strange fancy mutations coming up. So how do you interpret these mutations? And is there a fixed rationale that if, say, this mutation comes out to be positive, then this is the rational antibiotic combination to be used? How do you interpret these, resistance patterns on a multiplex PCR report?
So, sir, it depends upon the primary organism which is identified. So if you have a Klebsiella pneumoniae, you may have KPC, you may have the OXA48. So you can have different type of mutations depending upon the primary organism you identify. So the identification purpose is predominantly that you can try to narrow down your antibiotic choice, like I showed in my presentation, based upon like you have OXA48 positive organism, then obviously you are likely to use ceftazidime avibactam as your primary treatment. If you have NDM or if you have KPC, then you'll end up giving the colistin as one of the antibiotics or some of the newer antibiotics which are coming up. So this kind of pattern will guide you that you cannot use ceftazidime if you have CTXN mutation. You cannot use ceftriaxone as one of the antibiotics. So those kind of decisions have to be taken based upon the mutation you identify. Many times what happens, you identify two organisms. Like the report I showed in my patient, there were two organisms. One was Acinetobacter, another was Klebsiella. So you can have the mutation identified in both the organisms separately. So if you have two identified organism and two mutations, then you have to decide what is your primary therapy you can do, or you can give a combination for targeting both the mutation and organism, depending upon the clinical context, how hard pressed you are to treat those infections.
Sure. So question for Atri. Atri, people are asking what is the final word on fluoroquinolone therapy in Indian ICUs, Indian OPD setting? When do you use fluoroquinolones? I personally, I've almost stopped using them. What is your take on fluoroquinolone therapy as a pulmonologist? When should a pulmonologist actually bank on them? Should we be using them at all? And an off-track question, one of the most, the latest fluoroquinolones, the new kid on the block is levonadifloxacin, and a lot of people do come and push this antibiotic. So what is your take on it? Have you used it? You think it is useful?
Respiratory OPD setting, I would say no to fluoroquinolone. When I was a student or resident, threat of MDR TB due to fluoroquinolone was big. When I started practicing, one patient taught me this. Sir, if I survive this pneumonia, maybe then I can think of contracting MDR TB. So that was a very big learning point for me that yes, I need to save this patient now for that patient to be alive to contract TB later. So sometimes admitted patient, if I know this is a pseudomonas, high risk setting of pseudomonas, give a fluoroquinolone. I prefer levofloxacin. I use moxifloxacin less. As for levonadifloxacin, what they say that up till now the DST data for it is not there, and they claim it to be sensitive for everything from gram positive, gram negative, atypical, MRSA, everything. So maybe when I get a patient transferred from an ICU, or if an admitted patient deteriorates and needs an intubation, that is where I have used this levonadifloxacin. It has never been my first line antibiotic, but if there is a deterioration or I get a transfer patient, that is where I have used it, and I have found it to be effective. It is one of the maybe fastest acting or fastest leading to clinical recovery, but I've never used it alone. I have used it in conjunction with a cefoperazone or a meropenem coverage. So this would be my take on quinolone.
Sure, I think, and that is a point that needs to go across, especially to our physician colleagues, that using fluoroquinolones as an OPD setting antibiotic is something that should not be done. Very rightly said. Question for Professor Parvez Kaul. So a lot of us work at tertiary care centers and do deal with a lot of patients, who are bone marrow transplant recipients, someone who's a liver transplant recipient, someone who's a kidney transplant recipient, patients who have advanced immunosuppression due to multiple reasons. And a lot of these patients do come up with neutropenia and pulmonary infiltrates. So in your clinical practice, what is the rationale antibiotic coverage that you would recommend in someone who is neutropenic and has pulmonary infiltrates?
So this is a very highly individualistic setting. I mean, whenever you are talking of managing patients of whether immunocompetent or even immunosuppressed, specifically immunosuppressed patients, you should look at the local ecology and the local antibiogram of any person. So there's no one size fits all for this. And whenever we have a patient, please look at the local ecology of the microbial flora of your place and see what is some that you need to cover. You generally give them a very broad antibiotic cover so that we don't risk the possibility of them degenerating into a very severe sepsis or a bacteremic state. But I would certainly desist from giving an antibiotic prescription on this national level panel discussion for anybody. Please look at the ecology of your own hospital, of your own setting, and devise an antibiotic program in your hospital depending on the flora that you have prevalent that is given to you by your microbiology department.
I think that is the best way to summarize it. And I think a very important message that everyone is trying to put across is we need to have local data. All of us need to have our own antibiograms. And it is very difficult for infectious diseases, to kind of put forward a prescription which would be suitable pan-India. So I think that is a point that you've said multiple times, and I think we absolutely take it that we need to generate our own data and probably, individualize. For example, in a lot of settings, a lot of ICUs in Delhi NCR, around Delhi NCR, we do get a lot of gram-positive sepsis. So of late, we've been getting a lot of patients transferred to us, and we do culture MRSA in these patients. Now, as per the conventional guidelines, you would not start MRSA therapy for a lot of these patients, but we've become wiser. And based on this past experience, we would, kind of in my hospital, this is something that I'm talking about my hospital, we would kind of, in the selected patient population, start MRSA therapy up front. So I think the point to put forward here is that we need to have our own antibiograms and treat and, individualize therapy. And this is a very important point that, cannot be emphasized upon more. So a question for Sachin here. Sachin, a lot of new resistance breakers are available in the Indian market. For example, ceftriaxone with EDTA. The data is kind of wishy-washy, as is the data with a lot of these newer antibiotics, for example, levonadifloxacin. And as Atri also said that, the antibiograms and the sensitivity patterns of these antibiotics are not very well known. How do you interpret the data of this particular combination of ceftriaxone with EDTA? Do you ever use it, and what is your take on it?
So I think ceftriaxone with sulbactam with EDTA is one combination we have been using right in and out, and I think it was one of the antibiotic I also showed, which is commonly prescribed in our ICUs as well. So LRS we started using long back. It's not a new drug, so we have been using for almost last 4 to 5 years. I would put it like that. So the main thing, what the highlight was, is the addition of EDTA moiety to the ceftriaxone with sulbactam combo. So EDTA is considered not as an antimicrobial thing. It is something where it kind of breaks the resistance by reducing the efflux transporter mechanisms. It also, to some extent, reduces the biofilm. But the hype that has been going around adding EDTA to ceftriaxone, I would say that most of the work is done by sulbactam rather than the EDTA, and the credit goes to EDTA in the combination. So ceftriaxone sulbactam itself is a great combination, and we have been using that for most of the ESBL Enterobacteriaceae bugs. The main advantage we faced when you're using LRS is a carbapenem sparing effect. So we can avoid using meropenem in most of these patients, and instead we can go and switch to LRS. And when it comes to our ICU, especially in our Fortis ICU, we have a policy. If any patient we start on carbapenems, I need to write a big explanation to my microbiologist as to why I'm giving empirical carbapenem to them. So if I want to avoid that thing, LRS got a better option, and we have been using it for most of the ESBL bugs, and it does give a good response. But I think the hype around EDTA should not be too much. It's more of the sulbactam which does the job, I guess.
Sure. So I think all hospitals have their own policies on this. For example, my hospital has done away with this antibiotic. They would not let us use this antibiotic now because they're not convinced with the data. So a lot of, ID people sitting in their ivory towers do dictate these terms to clinicians these days. And unfortunately, most of these microbiologists and these ID people would not even come to the patient bedside, know the history of the patients, and they would just comment on these, pieces of paper sitting in their chambers. So I think when it comes to clinical medicine, the baseline theory, you can discuss so many things, and you can discuss the latest data and papers and whatnot. But when it is you versus confronting or vis-a-vis the attendance of the patients, and when you have to save the life, I think in our clinical judgments, these microbiologists, and no offense to anyone, these ID people should actually come with us on rounds and see what we actually face, rather than, writing beautiful papers and writing commandments and telling us what to do. So for example, I had been using in my previous hospital this antibiotic, and I could not really find fault with it. I'm not saying it is a fantastic antibiotic or this is something that I recommend or something, but I could not really find faults with it. However, now this, the kind of papers and the kind of data that people are looking for, if this doesn't satisfy them, people would actually write away with these antibiotics, saying that the data that is there is not good enough to support the use of antibiotics. So I think we need more indigenous data. We need more data from our country, our antibiograms, how our bugs respond to these antibiotics. And I think we would be able to take this forward in a better way then. Last couple of questions. I know we are already running out of time. Atri, this is for you. Bronchiectasis is something that is very commonly seen in the Indian context. A lot of us do see exacerbations of bronchiectasis. And as I've been asking a lot of people, what is your rational antibiotic combination? How do you start therapy for this? Obviously, there is no pan-India prescription, but in your clinical setting, what would you do if you see a acute exacerbation of?
Very quickly, I got a case today, 60-year lady, left upper lobe localized bronchiectasis, history of bad COVID 2 years ago. She was asymptomatic in the last 2 years. This was her first exacerbation. She was hemodynamically stable. I gave her cefditoren BD, 5 days. She responded wonderfully. Now, if I want to translate again, early history, late history, less than 1 year to less than 2 years is early history, treat as CAP. Whatever is good for CAP is good for this acute exacerbation of bronchiectasis. Greater than 2 years, or if the patient needs one admission with a hemodynamic compromise, please suspect gram-negative enteropathogens are growing now. try to get a BAL. I try to convince these people for a BAL, that early BAL will help you for your long term. And if I get something bad in the BAL, then after treating as a complicated cap, maybe with a extended spectrum cefoperazone, cefepime, and a levofloxacin, after that, these people, I keep on that on-off nebulized colistin or not colistin, nebulized tobramycin also. So this is my take on infective bronchiectasis, sir.
So I think bronchiectasis, because a lot of us do tend to, see a lot of gram-negative bacilli in these patients. So the rational antibiotic policy would consist of something that covers Pseudomonas. So that is the message that we need to put across. A very important question, and I think there could be no one better than Professor Parvez Kaul to answer this. A lot of us do see a lot of viral ARDS and influenza, sir, with secondary bacterial infections. So what is the rationale of starting antibiotics in people who have so-called supposed viral ARDS and patients who have proven influenza infections? What is the role of starting antibiotics in these people, especially in the ICU setting?
So, Arjun, that's a very important question, and that is something that we are all always grappling with. We have a patient who comes sick, and we just don't know what he has. And until that time, I would certainly say, specifically for the purpose of influenza, if you have a patient who is sick and he has, I mean, COVID is gone, we no longer think of COVID. But if it is in a time when you expect influenza circulation, then I would strongly suggest that in addition to the antibiotics that you give to the patient, do start him on antiviral agent as well. And once you are getting a diagnosis based on your investigations, be it point of care testing or based on your cultures, and you understand that there is only a viral pathology, then there may be a point for you to de-escalate. That is where probably your procalcitonins, your WBCs, your CRPs, and your other parameters help you. That if it is an isolated viral infection, and we have demonstrated previously that we can de-escalate these patients, specifically in the setting of acute exacerbation of chronic obstructive lung disease, we have taken them off the antibiotics, put them only on anti-influenza treatment, and then actually done very, very well. So once they come to you, that time probably you have no choice but to start on a combination of antivirals as well as antibiotics. If you are in a setting where you have an circulation of a particular virus. However, because if you talk of viruses, the one virus that actually can be managed is influenza. Rest, we don't have too many antivirals against other, and then we had COVID. I mean, so if you have a patient coming to you, long story short, give a combination, then try to de-escalate based on the investigations that you receive.
All right, great point, sir. Last couple of questions. Nitin, sir, this is for you. I think a lot of questions on ceftazidime coming, and I have been told that a few of our panelists have good experience with this antibiotic. I have none. What is your take on this antibiotic, and is there any difference in the dosage? I think Atri was mentioning something that there's a difference in the dosage between when you give it for pneumonia vis-a-vis OPD settings. How do you change that, and what is your take on this antibiotic?
One, I like this antibiotic, no question about it. I've been using it extensively. It is an antibiotic which has not been picked up by the physicians. So that is one novelty to the So the most of the organisms are, they don't know this antibiotic. So that is one good point. It does cover some amount of Klebsiella, not drug-resistant Klebsiella, obviously. It does cover your big three. So your Moraxella, your Haemophilus influenzae, and your strep pneumonia is uniformly covered. There is almost no documented resistance to strep pneumonia. So I think that is one good additional point. The availability in the bronchoalveolar areas, I mean, the respiratory linings, alveoli is excellent. So there is no issue of bioavailability. And if at all I have to argue with Atri on this, I might err on the side of giving that 2 BD rather than 1 BD. So 200 milligrams 2 BD rather than 1 BD, because I'm very, very afraid kind of a pulmonologist. I'm always concerned about the eventual drug resistance erupting. If I have to give an antibiotic for 5 days and the patient is more than say 50 kilos, I will generally end up giving him 2 BD, assuming that it is severe rather than a milder infection. I can't clinically differentiate something milder from severer forms. So I would rather give it, 400 twice daily. And I wish they could come up with 400 once, one tablet BID. It will be easier for the patients also to remember. But beyond that, I think it's a good antibiotic, can be used sensibly, and I think they should continue promoting it to pulmonologists only. Let us have something in up our sleeves rather than everybody using cefodoxime and whatever, everybody knows every antibiotic, or even that levoleucine. I mean, everybody is using it, and therefore I don't find a real reason to use it.
Fine, sir. Point very well taken. I think they need to come to me also. I have no clue about this antibiotic, and I'm listening everyone today. I would want to actually try using this antibiotic. So just to summarize, I think I would thank all my panelists for being so patient and answering the questions so wonderfully well. So a lot of important points have come about today. I think the most important thing is that we need to have our own data. We cannot generalize antibiotic prescriptions for everyone. And as everyone says, we need to be rational with the use of antibiotics. And this rationality and step down sometimes is more of a theoretical concept rather than a practical concept. The bottom line is to save the patient. However, in doing so, we must not lose track of science. We must not be deviated by interests of the industry or by antibiotics which have no data as of now to support them. Sachin has told us about fantastic new combinations which are on the horizon, and I think they're very, very important because in the next couple of years, probably we would run out of a lot of antibiotics, and we need newer kids on the blocks which would target these newer bugs, the more resistant bugs. And I think the times to come would be very, very exciting, where a lot of these new tongue twisters, we would actually be using them in our clinical practice. Saurabh has told us in details about the multiplex PCR, and multiplex PCR is something that all of us have been using. And I think as the system gets more crystallized, as things get, as we become more intelligent, and as the lab tests become more intelligent, and we understand the interpretation of these tests in a better manner, we'll be able to use these tests better. The biggest problem with all multiplex PCR is the number of multiple bugs that come up. And I think, as Dr. Abhyankar told us, that it is the clinical setting which is most important. And rather than targeting everything and treating everything, it is the clinical scenario which would help you target what has actually been, which is actually the bug that you need to target based on the multiplex PCR report. And with that, I thank all the attendees today. I've been told that we have more than 1,500 people listening to us today. Thank you to everyone for very patient listening. Always a treat to interact with Professor Parvez Kaul. We always end up learning so much. Thank you, sir, for being here today. Thank you, Sachin. Thank you, Atri. Thank you, Saurabh, for being here today. Thank you, Nitin, sir. And thanks to Team ICS for doing this. I think pulmonary infections is something that can never go out of vogue, which can never go out of fashion, and something which continues to evolve. And every day, when I see Professor Parvez Kaul's status on ResearchGate, when he's asking the younger generation to do something more, to come up with more research, I think that is something that we need to learn from him. The zeal and to work towards this and to make a name as he has made is something that we need to learn from him. Thank you so much for inspiring all of us, sir. Big thank you to all the panelists for being here today. Have a great night ahead. Thank you so much. Good evening, everyone.
Thank you.
sir.
Good evening.
Thank you, Dr. Amita, Dr. Sandeep, Dr. Raja. Thank you. Thank you, everyone.
Thank you. Thank you.
Thank you, everyone.
Thank you.